Just getting everyone kind of admitted to the group here. So give us one moment and then we'll get started. Cool. Well, I hope you're all having a good day. Academic Half Day today is focused on COVID. And so we have two awesome speakers for our first hour. So Chloe Bryson-Cahn and Maggie Green are both coming from the infectious disease department and are going to be here to answer all of our questions. Just a little bit about how the morning will go. We will hear just a little bit of an update about kind of where we are with COVID right now in Washington State and UW in particular. And then really this time is to have all of your questions answered. And so I encourage you to leave questions in the chat. I also, if you would like to unmute yourself and ask questions, that's also a great option too, so that we can hear from you. So with that said, I will pass off to Chloe and Maggie.
Great, good morning. I was just going to share a little bit of data first to sort of set the stage for the rest of this conversation. I think Maggie and I probably spend all of our day looking at data for King County and the state of Washington and the rest of UW regarding COVID, but I suspect all of you do not. So just wanted to share the amazing King County resources that are available with you guys, and then just look at the trends over time, because I think it's nice for sort of remembering what a surge we continue to be in COVID-wise.
And also a plug for our data always being so available and transparent, because we are very fortunate to be living here where that is, living and working here where that is the case.
Definitely. Okay, can you guys see my screen?
Yes.
Taking silence as a yes. Okay, so these are the King County COVID dashboards. I just search King County COVID dashboards, and these are the first hits. There's tons of great ones, but I would say the daily summary dashboard and then the recently updated COVID-19 outcomes by vaccination status is amazing and very good data for talking with patients. So this is the, the daily summary dashboard. I think just gives us a nice eyeball on sort of the trends of positive cases, which is here. Hospitalized cases and deaths are the big areas where I tend to look. So the x-axis here dates all the way back to March 2020. I know we hear people talk about a fifth surge, and I've heard people ask, are we really in a fifth surge? We most definitely are, counting 1, 2, 3, 4, 5. And just a reminder to folks who it's not your first year at UW, this surge that we're in right now feels like a lot. It feels like we're seeing a lot of very sick patients, and it reminds us all of fall 2020. And that is because it is a lot like the surge in the fall of 2020. I think this surge got a ton more press. I think our community was much more engaged at that point, and I feel like there's a really big disconnect between what's happening in the state and our community and what's going on in our hospitals. So just want to give a little bit of recognition to what is happening here and now. Just a little note that that gray bar at the very end on the right side of the x-axis there is incomplete data. So though we see a little bit of a downtrend, that data will still continue to come in for the next 2 weeks. And so my suspicion is that will raise a bit and that we are really in a plateau and not a drop. I think we were all hopeful when we saw that first decrease, but it came right back up. Has a lot to do with availability of testing and holiday weekends and things like that. So I think, you know, we're not shooting upward anymore, which is good, but this is sustained really high level of transmission of COVID in our area. Some people are more hopeful than me, but I have become a major pessimist over the last year and a half. And then just looking at hospitalized cases, we are seeing a ton of patients in our areas. This has actually dropped a little bit, and we're also seeing a drop in our specific hospitals as well, which I think is good news. And then the death rate sort of has been hovering around 1 or 2 or 3 a day for the last several months, but we did have a little peak recently. And a lot of this is happening in Harborview, which is where I am based, where we get a lot of the ECMO consults for all over the region. And I think what's sort of notable here and remarkable, so this was all the elderly patients coming into our hospital, mostly from nursing home outbreaks, who were sick and dying from COVID. This is young people, and I think that's really been sad and hard for all of us to see. Just looking at the case and hospitalizations, can you guys, did my screen switch there? Okay, so this is the newest dashboard, which I think is just an incredible tool, so wanted to share it with all of you. This is looking at age-matched folks who are vaccinated versus unvaccinated and risk of acquisition of COVID, of being hospitalized from COVID, and of dying from COVID. So I just find this incredibly reassuring as a highly vaccinated healthcare worker population for all of us, but also a really good tool to talk to patients who are experiencing vaccine hesitancy. So 7 times more likely to develop COVID if you are not fully vaccinated, 41 times more likely to be hospitalized, and 42 times likely to die. People always ask, why is this the same as this? Sometimes this has been lower. It's a small numbers thing, I think. But I think the point here is that our vaccines, though they are not perfectly protective from us getting COVID, they are incredibly protective from helping us not be hospitalized from COVID and not die from COVID. So really excellent tool. If you have trouble finding it, please let me know. And then I'll just share our local numbers quickly for all of you to see. So this is Valley Medical Center, Northwest, Montlake, Harborview, and our totals. Our totals for the last couple weeks have been up in the 90s. So to see numbers in the 60s, I think is reassuring, and maybe good news that we're seeing our numbers decline. Overall, Valley tends to have a ton of patients in acute care with COVID. Montlake, Harborview, a lot in the ICU, and then Northwest seems to be a pretty good split. Just a shout out that Northwest and Valley are much smaller hospitals than the other hospitals, and Valley usually has 30 or 40 folks with COVID, which is pretty remarkable. And then I think the final note here is Harborview has 35 patients in quarantine, which is patients with high risk exposures who do not have COVID, but are at risk of developing COVID more than all the rest of us because of a high risk exposure. Many of these happen in the hospital. We're having a couple of ongoing outbreaks at Harborview related to congregate settings. So I think those of you who've been at Harborview recently know we're super crowded, lots of folks boarding in the ER, in the PACUs, in the TCU. We used to get away with this, I think, in the non-Delta days, but now that we have the Delta variant circulating, which is just much more infectious, our congregate settings have become a big risk. So we are doing a ton of work to try to make these places safer. I think the biggest thing for you guys to know is that though it's been in our guidelines forever to mask patients when we interact with them, nobody masks their patients. So we come in masks, but what really makes an interaction safer is if I'm masked and my patient is masked. So we are asking every time you guys go in the room, bring a mask, ask your patient to mask. I know patients push back hard and it's difficult and it's a hard conversation. I've been there, I understand it, but I think if we all present as a united front, we are going to have much more success doing this, but it's just the expectation. When I walk into the room, you mask. When your nurse walks into the room, you mask. When nutrition comes, you mask. It's just the way we do things. And I think we need to do that across the system to increase safety for all of us. And if you have a visitor in the room, you mask. So those are my big messages. I'm going to stop talking now and pass it off to Maggie for anything and here to answer questions.
It looks like we already have some things in the chat. I think someone wanted to see a breakdown of the vaccinated folks who were older. So just to point out that those are age matched. So even young people who are unvaccinated are 42 times more likely to be hospitalized or 41 times more likely to be hospitalized. We don't have really good data about immunosuppressed, and mostly that's because that is such a hard thing to measure and keep track of in an accurate way. But I would say that if people have the impression that if you're healthy, that you won't end up hospitalized, I think that's wrong. And we are seeing lots of healthy people and certainly a fair number of pregnant people very sick with COVID. So really trying to get that message out there that pregnant people should get vaccinated. There's a question about outbreaks. Chloe, do you want to tackle that one?
Absolutely. So we do, whenever there's an outbreak, sort of defined as 3 linked cases, We do a huge amount of work, including tons of surveillance testing. We call it case finding testing for anyone who works on the units. We don't often, interestingly, find infections in our MDs when we do this, so we don't hunt you guys down like we do the rest of the staff. I think this is really sort of how we spend time on units, how little time we spend with our patients, moving from room to room to room, versus nurses and HAs who spend tons of time with patients. But we are always happy to link you guys in if you want to do and participate in testing, and these messages should always go out to you guys. But tons of work doing case finding, talking to all the people involved, trying to figure out where these infections came from. We have good eyes on our testing site at Harborview and Montlake, and so can really attempt to link all these cases together. We also send for genotyping at virology and the state lab, who can often do nice phylogenetic trees for us to try to link cases, but those come way down the line. And yes, unfortunately, we have traced several of these outbreaks to visitors, which is why we just shut down visitors at Harborview, and to ill staff who have worked while they were sick. So just a huge reminder to everyone, if you have even the drip of a nose, please let employee health know. We have rapid testing capabilities, and also really good testing and great backup from your residency program. But again, it's not generally the physicians who are bringing COVID into our units. I think, just sort of all joking aside, we don't spend a lot of time with our patients. So I don't, for what that's worth, but we did just stop visitation at Harborview because of this.
There's also a question about with the way we're seeing now with the kind of younger, healthier population. Is there a sense of how many of these people do have underlying comorbidities like obesity and metabolic syndrome?
Yeah, I can speak to the ICU at Harborview. I looked at just the hospitalized folks in our unit maybe 2 weeks ago, and the average age was 40. Mean and median, which was sort of startling. A lot of folks on ECMO. I can't tell you proportions, but there were a lot of people with obesity and sleep apnea and diabetes is what I remember seeing, but not everyone. So it does seem like comorbidities do predominate as a risk factor, but I don't think it's that way for all of our patients. I don't know, Maggie has a much older patient population at Northwest.
We do, but we've also, I mean, I think most of our ICU patients are coming from other hospitals at this point, transfers that don't need ECMO because we don't have that capability. So a lot of our recent ICU patients have been from Tri-Cities, for example, and, you know, young, maybe overweight, maybe obese, but certainly not, you know, previously on medications and not showing any signs of prediabetes or diabetes. So I would just say that, you know, the virus is bad for them, and they're getting, you know, Delta is different. Delta is just so different, and people are getting much sicker. And that may be because they're getting higher viral loads. I mean, people are just so much more lax in their kind of social interactions than we were months ago. And so maybe getting a higher inoculum and getting sicker faster. You know, we're not doing those kinds of studies in our patients in the ICU here, but it seems like when you take a good history of like, you know, what have these people been up to, you can really learn a lot.
And then there were two questions about boosters. One was about kind of the data, and, you know, now with the FDA approving it. And then another question kind of a little bit about the anticipated timeline of that rollout.
So yeah, so the FDA has met for their approval process twice now, last week and yesterday, to talk about just Pfizer with regard to boosters. ACIP, which is the, oh gosh, the American, Maggie help me out, of something immunization practices, which is an independent group of
advisory committee.
Good, thank you. Who work for the CDC, through the CDC, but are independent and come up with all of our vaccine recommendations, which is really what we follow. They have not met yet. Our meeting, I think today or tomorrow, to come up with formal recommendations. We usually wait for ACIP before we do anything. But they have sort of followed along with the FDA for all of COVID things. So I don't anticipate that their recs will be very different, but we really do want those folks to weigh in. So yeah, so approval for folks for Pfizer boosters only for folks older than 65, people at high risk of progression, which hasn't been well defined yet, and that's what we're waiting on ACIP for, and people who have a high risk of exposure through their jobs, which I believe is healthcare workers, probably will be healthcare workers, people who work in public transportation, et cetera. So I think we'll know more a little bit later this week. Maggie, I don't know if you have anything to add.
Only that, I happened to listen in on the conversation last week where they were really singling out healthcare workers initially, and some of our colleagues sort of tried to broaden it to say it's not just healthcare workers who are at high risk of occupational exposure. And we really need to be a little bit more broader in our understanding of who is at high risk for occupational acquisition.
So we'll know more soon. I think UW is ready to roll as soon as these recs come out, but we're going to wait until they formally do. And then I think we haven't heard anything about Moderna yet.
We haven't heard anything about Moderna yet, and we haven't heard anything about mixing and matching yet. So there are ongoing studies, but I think for those who received Moderna first, the first 2 doses, I don't think the initial rollout will be to offer a Pfizer booster to them if the recommendation is for Pfizer. It will be only for people who already received 2 doses.
And then I did hear J&J just filed with the FDA for second dose yesterday. So hopefully that meeting will happen soon too. But I think the thing that we also are all waiting for is children 5 to 11 should be really soon. And then hopefully children younger than that as well. Because I think as we think about community protection, we're seeing a lot of spread through kids. And so it would be really nice, I think, for maintaining our healthcare workforce, keeping all you guys who have kids at home feeling a little bit safer and more protected, and then just as a community intervention.
What other questions do you have? Feel free to unmute yourself and ask on video as well.
I feel like Mac put this in the chat, but I just wanted to echo too that I feel like maybe not the only, but the times I felt the most unsafe at work exposure-wise has been in the Harborview ER. And it feels like that has been the case in waves like 1 through 5. And there's been like some changes, but still ton. And like, if someone's in blue ISO, it's fine, but oftentimes there is more than one person and blue ISO is taken, and then it feels much less safe. And I think sometimes when you're working down there full time, like you have space to like know where everything is, but it's like when you're coming down to admit someone and you're just there like for that one interaction that like people, it feels like, are just like showering COVID all over One East Hospital, and you're just like hoping that your PPE works well. And I'm curious if there's any thought or approach around like beefing that up or changing that, or is this just like the limitations we have?
Yeah, absolutely. I mean, this has like been one of my biggest fears in this pandemic, has been what on earth is going to happen in our emergency department at Harborview. I agree. It feels at times incredibly out of control down there, especially just because the hospitals are so crowded right now. And when we crowd everywhere, the ER just sort of overflows at Harborview. And even the waiting rooms, right? We don't count those patients in our borders, but like those waiting rooms feel like a lot. So I think the one big saving grace at Harborview has been the air handling in the Harborview Emergency Department. We had a big Ebola grant a couple of years ago that we used for updating the HVAC and airflow systems in the emergency department. And basically there's huge fans that suck fresh air into the emergency department, and then everything gets pumped out onto the street. And I think honestly, without that, we would have been in deep trouble in the Harborview Emergency Department for a long, long time. Even the PES rooms, I don't know if you guys spend a lot of time in the PES, but really small space, super crowded, feels like there could be no airflow in the whole wide world in there. Even there, the rooms turn over almost like a negative pressure room would. And I think that's really what has saved Harborview, is the way air handling happens in the emergency department. So an invisible thing, but a really helpful thing that has increased safety that we sort of have, keeping us all slightly more safe, but I don't think that it sort of excuses the rest of what's happening in the ER. So we recently asked that folks working in the emergency department preferentially start wearing respirators, so N95s or PAPRs when they're down there. I think you guys should feel the same, free to do the same when you go down to admit patients, especially if you're going to be down there for a long time in a congregate setting in the emergency department. We're trying to increase a little bit of availability of rapid testing, especially for folks who are like stuck in the hallway for hours spitting and shouting. We felt like those people would be good candidates for getting a rapid test so we could know that they were negative. And then I think just pushing masking of our patients. And then we are constantly in discussions about with the emergency department about how we can find more space. We have talked a lot, I don't know if you guys remember, but at the very beginning of a pandemic, we popped up that huge tent on 9th Avenue right outside the ED, and we were seeing patients with mild respiratory symptoms out there. And we have talked a lot about whether bringing that back would make sense. I think the problem is there were super low acuity patients being seen in those tents, and it was being staffed by primary care docs primarily, whose clinics were closed because of COVID. So I think for several reasons, it's not a great option at this point, but it's definitely up for discussion. And if you guys see things that feel unsafe or have ideas, please reach out and let me know. I think, James, I share your deep concerns about the ER. I feel thankful for our air handling, and I think, you know, step up your PPE a little bit is really what we've gotten. And we've been working with the ER a lot on who needs to be prioritized for being in ED Blue and those small ISO rooms, and it's really folks getting aerosol generating procedures. So people who are getting intubated, people who are on CPAP and BiPAP, those folks, NEBs, we want in ISO for sure to slightly decrease risk, but I agree. And I think maybe helpful. We don't see, you know, this big outbreak that we've just had at Harborview was in Resus 4, where folks were boarding for 7 days. But we are not seeing outbreaks in the ER spaces themselves. That was an inpatient unit. So interestingly, and not a lot of ER providers or staff have gotten COVID. Some have, but not a lot. So just interesting. Sort of, we look at those numbers really carefully to see if there's a problem, and we're not seeing them look concerning. I don't know, for whatever that's worth.
Are the ER providers down at Harborview wearing respirators?
Sometimes.
But not always.
Not always. It's hard to wear a respirator for a whole shift.
I know, yeah. I think most of ours at this point are. Most of our providers are, and nurses, but.
And there was a question about like medical reasons to not get vaccinated or contraindications. I think I've certainly seen this come up in my primary care clinic, people coming in asking for letters of exemption.
So the main one for not getting any vaccine, you know, even a first dose would be, you know, a PEG allergy, a polyethylene glycol, you know, immediate severe reaction, which are very exceedingly rare. So I haven't given any medical exemptions. I think if someone had a first dose and then also had an anaphylactic response to that dose, that would also count as a medical exemption to complete vaccination. And I don't think I'm missing anything else.
It's super, super rare. I think that's the takeaway for you guys. And there is a form, I think Lisa Chu is modifying the form that we made for employees for clinics so that you guys can use it, but it basically has like the 2 accepted medical exemptions and then a write-in option. But it's very little, and there's good info on the CDC website as well if you guys feel like you need to fill it out for a patient.
What are, maybe if I can ask back, what are some of the reasons that patients are giving that they want a medical exemption?
Rebecca, I don't know if you want to comment on kind of what prompted your question. Someone did ask about Guillain-Barré, which I know is specifically not a reason not to get it per the CDC's website. Conversations I've had around it are more just kind of general vaccine hesitancy and seeing if they can get away with a medical exemption.
That's my experience too, is people are like, I was told once I have heart palpitations. This could make it worse, but actually I'm opposed to the mandate.
Okay, sorry, I got behind on moderating the chat here. Let's see. So it sounds like.
Can I just an exemption thing? I think we've had a lot of ID providers, and I don't know, Maggie, if you've been asked, but asked for a physician to sign a religious exemption. And we are specifically recommending that we not do that. It is really not our realm to get into that with folks. It's also not a, right, it's not a medical exemption to sign. So if people have a religious exemption, they need to talk to their employers specifically about that. But we should definitely stay out of religious exemptions.
Okay. And there was a question from Arita about patients kind of going off on their own to get boosters, kind of outside of the FDA recommendations, and kind of what our guidance should be on that.
I've definitely heard of that. A lot of people, not just patients, healthcare providers too, going to retail pharmacies and getting a third dose. So I am encouraging people not to do that. I don't, I think that my arguments against it are just more about like, we're just trying to do what's best for the most people. And we don't, until we have the guidance, we also don't have the protection. So if people are going to do that, I'm not going to tell them, there's nothing for me to do about that. But I would encourage people just to wait for, the guidance to come so that people who are reviewing the data can determine. I mean, I think the conversation last week was very interesting because people were really, unsure that we needed to be offering boosters to all adults. That it just didn't seem like the data was that clear that it was a good idea for everyone over 12 and up. So I think the data is not a slam dunk, and people are saying, yes, maybe it makes more sense for those who are at higher risk of severe illness or at higher risk of occupational exposure, but maybe not for the general public.
I think the other really compelling reason not to encourage people to go to the pharmacy and get those booster doses is that we can't then track those people as someone who's gotten a third dose. And what we have learned, the vaccine trials are big, but these huge administration rollouts that we do in this country help us learn about super rare side effects from these vaccines. And if people are getting sneaky, sly vaccines on the side, the information is going to be trash that comes in, and we're not going to be able to detect rare side effects. So what I'm telling my patients and my colleagues and my family, who asks me every week if they can go to CVS and get another dose, is like, sit tight, do the things we know work. It's coming soon, and we'll be able to better track it and learn if you guys can just hold for a little bit longer. So I don't know if that compels anyone but me, but feels important to me.
Okay, and then two other vaccine related questions. So one is about when people who have been sick with COVID are safe to get a vaccine or like a booster. And then another question about getting an mRNA based vaccine after the J&J.
So mRNA after J&J has been studied. Even UW was a site for a big mix and match study is what they called it. And I have not seen the data yet. I've heard that people get huge immune responses, but I haven't seen it published. So hopefully it's coming soon. I know the arm of the trial that was run at UW was closed a long time ago. So they should have enrolled significantly, and hopefully we'll see it soon. I suspect, there's some AstraZeneca in England with mRNA afterward that also was reportedly really effective. So we'll know more soon. We just don't know yet. And then again, J&J boosted with its own, probably good too.
What was the first question about?
The first question was about like people who've had severe illness with COVID and timing of when they can get vaccinated.
I think as soon as they are able, I mean, there's no indication that it would cause any particular side effects. So, it'd be great to give them vaccinated before they even leave the hospital.
Great.
Yeah, CDC says once they're out of precautions, no longer in isolation.
Great. And then there was another question about, I think a lot of us have had to do a lot of like vaccine counseling in our primary care clinic. So when we're asked about like rare side effects, do you have any guidance on what we should be citing as, rare side effects of the mRNA vaccines? Just since there is a lot of hearsay with this.
You know, there's an amazing CDC website that I will try to pull up and put in the chat that for J&J and the mRNA vaccine goes through sort of the very severe side effects. So the thrombocytopenia with clotting for J&J, Guillain-Barré, and pericarditis for the mRNA vaccines. Goes through the rates of those, breaks them down by age and gender, and shows you the risk of hospitalization, death, versus those side effects, and it's fantastic. So let me find that and put it in the chat, but I love to show patients and healthcare workers this resource.
And then the other thing is infertility concerns. So that's actually also been studied, and there's no data to indicate that there's any signal. And also, you know, for spontaneous abortion or miscarriage, there's no indication that there's a risk of that in patients who get the vaccine. There is certainly a risk of preterm labor and, you know, fetal demise in pregnant people who get serious COVID. So it's a huge risk that pregnant women or pregnant people are taking on. In terms of people saying, I think it looks like patients who declined second vaccine dose due to side effects, that's not a medical exemption. So, you know, we can try to better support them through their symptoms, but it would not be a reason to not get your second vaccine.
What else? And please just re-type in your question if I happen to overlook it in the chat. Sorry.
This is Annie.
Oh, go ahead, Annie.
Okay. I was just wondering about your thoughts on outdoor spread and whether with Delta we should be more afraid of being outside with our friends eating.
Yes, be more afraid. I saw your question. That's funny. That's when I unmuted because I know you asked that early. So Delta seems to be much more transmissible. And I think that we are all struggling with whatever we started to do this summer when things were better in terms of social interaction in summer and spring, and now really needing to pull back. So, you know, yes, it seems like outdoor, it made me very nervous to see the Seahawks game and see so many unmasked folks sitting pretty close together with a fair amount of yelling. Same thing for the Husky game. You know, there's just a lot of unmasked stuff going on. I've definitely in my own social life, and admittedly, I want to be able to come to work every day. And also I have 2 unvaccinated kids at home. So I have stopped doing pretty much everything. I have, you know, a few people that I eat outdoors with, socially distanced with about once every few weeks, just to kind of, you know, have a break, but otherwise nothing.
Cool. And then
Sorry for that downer, but
there was a question about menstrual irregularities that are common after the vaccine. And I'm not sure, Chloe, does the ACOG resource that you cited, does that provide any comment on that, or is that more about pregnancy?
Pregnancy.
Okay.
But I actually think Nikki just answered this question.
Yes, she did very well. And then Cody, kind of switching gears, which I think is a good question, is if we could talk about outpatient treatment of COVID and what our options are currently with monoclonal antibodies, et cetera.
So pretty limited. There have been some convalescent plasma trials, but they haven't really borne out. There was a big remdesivir trial that I'm starting to see preprint data for, but still a trial may be promising. Not doing it here. The one medication option we have is monoclonal antibodies, which we are giving at Northwest, Montlake, and Harborview in very limited supply and have a super, super short supply chain, it seems, suddenly coming from the state. So we have what we have. We're offering it, I think, to the highest risk folks, but it's definitely not an option for everyone given the supply and sort of the resources required to administer it. It's either IV or sub-Q. needs an hour of monitoring afterwards. So it's a pretty major thing. We have a monoclonal team of folks who review all positive outpatient cases within our system. So if your patient has a positive test within Harborview, within UW, they will review the case. You also are always welcome to fill out. There's a survey in RedCap. The information is available. You know, the yellow triangle on all of our desktops. If you click that and search for monoclonals, you can find the link to the survey, and you can also fill it out for your patient, but they will be reviewed if they're within UW medicine and offered monoclonals if they are high risk. They are not prioritizing giving it for post-exposure prophylaxis at the moment, just given the supply.
And
it is not a
also,
magic.
I don't think they're giving it to vaccinated people.
Unless super high risk.
Really
maybe 2 weeks ago before we had a supply chain problem. The medicine is not magic by any means. There's a small decrease in hospitalizations and death in people who get it, and certainly in folks who are already sick with COVID, so have an oxygen requirement. The original studies showed that it might be worse to give them monoclonals, so we don't use it inpatient for treatment. There is also a study going on through the Hutch. Maggie, maybe do you know a little bit more about an oral antiviral that's enrolling, but only high.
I don't know about that trial.
Okay, let me try to find the link.
And then James asked a question about remdesivir for inpatient care, and given the recent negative trials, if there's any discussion of kind of stopping this for standard inpatient care.
I don't think so, not yet. Not until we have something better to offer.
What else?
I had a question about, I know there's been a lot in the news recently, kind of, and I haven't like admittedly been able to go through all of it, of like the 3 vaccines and kind of like what we know about their various protection and when that wanes and stuff. I think I saw a recent study that there's some evidence that Moderna could, the immunity wanes a little bit more slowly. And then there's been like back and forth on J&J and the variant. So I was hoping you could spot.
I don't know if I have, a clear scientific answer, because I think the data is kind of coming from multiple different sources. But oh, recent grand rounds presentation. Okay. But I don't get the sense that the clinical benefit of Moderna versus Pfizer is much different. So, maybe the antibody levels drop a little bit sooner in some studies, but we're still trying to figure out what those waning antibodies really mean in terms of protection from clinically significant disease. And certainly when you're focusing on talking with your patients, I would just, really encourage them to get whatever vaccine they can get access to.
What else? Okay, a question about gamma and vaccine resistance.
Yeah, I don't think we know yet. Gamma seems to be taking over in certain parts of the world, but interestingly, we've had lots of variants that we have been worried about in the US coming along and maybe overtaking Delta, and that just does not seem to be the case right now. Delta is winning, Delta is champion, I think probably because it's just so highly infectious. These other variants have different advantages and things with immunity, but they just don't seem to be the concern right now. So I think we'll just have to see what happens. We are certainly worried about these and worried about any new variant that comes along, but for the moment, Delta really seems to be predominating, at least in our area of the world. Like 95% of our variants are Delta, and our virology lab watches this super closely. They see little signals of the other ones, but nothing major yet. So I think we'll have to see.
Oh, I'd love to hear this question about COVID and flu. So yes, I am very worried about a twindemic. Children's has already been full with not COVID patients, but COVID and RSV. So we saw a big resurgence this kind of late summer of RSV with, and now I expect that we will see more flu, just as people said, because we're doing a little bit less masking, we're spending more time together, or people are used to doing that. And also kids are back in school, and we know how efficiently kids spread flu. So I know that they're masked in there, but I also know what that looks like. And we're already seeing spread of COVID in schools. So I think we just need to really encourage people to get their flu vaccine as soon as they can. I don't think it's going to be like last year where we had no flu. And in fact, we've already seen our first flu A cases from, at least at Northwest, we've had at least one positive flu A.
And then a question that I don't think we had explicitly addressed earlier in the conversation around immunocompromised patients with the booster. What exactly is the wait period from their second shot?
So yeah, so I think we have tried hard to separate language, and it just is persistently confusing. So there's this issue of booster versus third dose. So booster is for everyone. That's the thing that hasn't fully been approved yet, and we'll learn more soon. Third dose was approved for Pfizer and Moderna for certain groups of highly immunosuppressed folks. And the goal is to give the same vaccine that they already had. So if they got Pfizer, you'd give another Pfizer. And I believe it's the same interval as between the first two shots, or like 4 weeks. So they do not need to wait for third doses. For boosters, it'll likely be 6 months after second dose.
That's very helpful. Thank you. And then guidance on timing for our flu vaccines. Normal to wait till November, or any other recommendation on the timing of when we should get flu vaccines?
It's always a huge tension. I see Maggie smiling also, between take the opportunity when you have someone in your clinic with their arm showing to give them their flu vaccine versus what's the perfect ideal timing. I think we always want to give flu a couple months before the big surge, but we never know when flu surge is going to come. And I think this year's probably even more unpredictable than prior years. So we will start rolling out employee vaccines on October 4th. I think patient vaccines are coming soon for flu, this week, maybe even the 28th. So if you have someone in clinic, just give them the vaccine if they're there, because otherwise we're not going to see them for 6 months, and asking people to get vaccines elsewhere we know doesn't work as well.
Okay, and then a question about long COVID. I don't know who wants to tackle that.
I think, so as a distinct entity, is there evidence for long COVID as a distinct entity, or is this another chronic Lyme situation? I think it is a distinct entity because it seems to be worse, or at least more common than other post-critical illness syndromes. So, I've definitely seen people, a year out still having some neurologic symptoms. But whether that's, we don't know the science behind it. So what the is it immune mediated, and what is the actual, basic science that's going to tell us that? But it doesn't seem to be a chronic Lyme situation. Chronic fatigue or, fibromyalgia, it's not a, it's real.
Okay, and Chloe did have to jump off, but she did put her email in the chat. If there's other specific infection control related questions that you want to reach out to her about later. Any other questions?
I just wanted to clarify. It's fibromyalgia is real. I was just saying that long COVID is separate from that. So they're definitely separate entities. We don't have good, I think, clinical criteria for it yet. And I think we're just still in the data collection area, I'll be really interested to see, the observational data that comes from the clinicians that are caring for these patients and kind of describing this. I think we have still kind of yet to go. And we certainly know that people who are unvaccinated are also at higher risk of having long COVID. So it's another reason to encourage your young adult patients who think, I'm not going to get that sick from COVID, to understand that they're also taking that risk of getting long COVID.
I will ask a question if that's okay. One of the vaccine hesitancy kind of concerns that I've run into a couple of times is with patients who had COVID previously and feel like their own body's immune response is enough to protect them. Do we have any specific data that's showing that immunity from having COVID in the past is waning quicker than the vaccine itself?
There is a paper that kind of describes that. So yes, we do know that. And I think, it doesn't seem to matter whether someone had a mild case or a severe case. So even, needing hospitalization does not protect you for as long as the vaccine. And I can look up that paper and send it to you.
Cool, thanks. What other questions? Any other non-vaccine, more treatment related questions that we want to ask?
This isn't treatment related, but I was wondering if there have been outbreaks in the homeless or sheltered population in Seattle recently, or if they continue to not have as high rates. Or...
There have definitely, so I work at the She Clinic up on North Aurora, where we serve homeless people. And most of them are not living in the shelters, but we've definitely seen outbreaks in some of our encampments up here. So I think, yes, Delta is different. So we're seeing more spread among people who are living outside.
Good. And then a question about treatment of long COVID symptoms.
I think that's going to depend on what your symptoms are. So there are clinics for long COVID where you can kind of send your patients, but for those kind of chronic fatigue, there is a lot of, I think, behavioral work that's going to, expectation setting and, goal setting and all of these things to kind of help people manage their symptoms. There's not really anything that will treat them. For sometimes that can also kind of lead to or trigger symptoms of depression. And so, treatment of comorbid depression may be helpful, or anxiety, but it really depends on what the symptoms are. What I haven't had good help with is figuring out for those patients who have not had return of their taste. And so are really just having a hard time enjoying life because they don't enjoy eating anymore. I saw some studies looking at kind of aromatherapy, essentially trying to kind of retrain their brain to recognize different smells using different essential oils. I've tried to help a few patients kind of figure that out, and it seems like it hasn't really been that great. So that's really hard.
Yeah. And there were just a couple plugs in the chat for clinics available within our system, both at the VA, AMC, and Roosevelt, that have long COVID clinics where you can refer your patients that may be having some of these symptoms. Cool. Any other questions? Well, we can take a break a little bit early unless there's anything else to cover. Yeah, thank you so much, Maggie, for being here with this, and Chloe, who had to jump off earlier. I think this was really helpful. So
Thank you. Yeah, we really appreciate it. I know how hard it is to be in the primary care clinics and in the hospitals. Everything has just been so full for so long. So thank you for all of that you guys are doing to protect our patients and each other and take care of everyone. Really appreciate it.
Awesome. Thank you.
Thank you, Maggie. Meg, do you want to start us back again earlier than our original plan, and then people can get out earlier?
Yeah, that's good. Why don't we come back at 10? Does that sound reasonable? Okay, I'll see y'all back then.